So here again, now you could take that and say, well, that was just a bad resident. No, this happened too many times with too many different people. Right? You begin to realize at some point this is a system issue. Right? And the system issue is the American healthcare system cranks volume because volume makes money. And the problem with volume is when I'm cranking as much volume as I possibly can, I can't be as thorough and detailed as I need to be to do good work.
Welcome back to Dear Healthcare, It's You. Welcome back to our podcast with Dr. Elisha Yaghmai, the founder of Free State Healthcare Clinic in Wichita, Kansas. Elisha, thanks for being here. We were talking last time about your medical journey still and kind of talking about why you are jaded a bit about the healthcare industry and why you care to talk about these things and help people be more informed. And so we're going through your journey. Where we've left off is that you told us that you started a residency here in Wichita, Kansas with Via Christi, and that after 1 year of that residency, you changed residencies. What happened? Why did you change residencies?
You know, I mentioned, I think last time, that the culture was different. So the irony actually was that, to some degree, that culture actually is what led to the change. So the very first thing was that at Via Christi at that time, we had a noon conference, basically. So you would go in, if you were on an inpatient rotation, and really anywhere, you would go in and do whatever you were doing, and then we'd have a break for a teaching session.
Oh, okay. For all the residents at the
yeah, or at least certainly all the residents on the inpatient rotation. I've forgotten if everybody came or not, but a lot of people would come.
Side question. Yeah. How many residents would there be at a given point in a hospital like Via Christi?
Well, there were, how many were there a year? 20 a year, maybe?
Okay.
So times 3 years.
That's a pretty sizable cohort.
Yeah, I might be a little off on the numbers, but it's in that ballpark.
Yeah, okay.
You know, and people came to the Via Christi from across the country, so it was a good mix of people from all over, right? That came in. And I would say that most of the people that came in had a similar motivation in terms of they were thinking about international health. They had an international fellowship that they started, I think, the year. Actually, no, they just started actually the year before I started, actually, if I recall correctly. That was one of the things that really attracted me to it. The international fellowship was meaning you would finish your regular family medicine and then you would actually go work internationally.
Oh, okay.
Right, in an underserved setting to gain more skills in that environment.
That they kind of hook you up with the slot for.
Yeah, that's right. So they had faculty that had worked in those environments, right, that had set up a program where you could go over and do firsthand hands-on training in those places. So a lot of the people that were coming in had that motivation. So, but the noon conferences at that time were taught by a local nephrology doctor, actually.
What is nephrology?
Kidney specialist.
Oh,
right? So he was internal medicine who had done a fellowship in nephrology.
Okay.
Right? So study of kidney. And he would teach basically the inpatient teaching session almost every day.
Every day you would have this noon
Well, at least during the week, right? So Monday through Friday, at least you'd have this conference, right? And he would come in and teach. And what she would do typically is the residents would present a case or two or whatever, right? And then he would go through and help you break it down.
Gotcha.
So he'd break it down into, you know, what did you do? Why did you do this? Did you do the right thing for the wrong reason? Did you do the wrong thing for the right reason? What was the outcome? How else could you have done this, right? But the common denominator in all of it was that this doc really liked medicine.
Oh, okay.
That's the best way I can describe it. He wasn't there because I don't know. He wasn't there. Like, in other words, this was not an academic medical center in that sense, right?
Yeah.
He wasn't there because his department head had told him he had to be there,
oh,
right?
Interesting.
He had to do a certain amount of time doing this before he could go off and do what he really wanted to do.
Yeah.
He just liked teaching and he liked medicine, and that attitude, at least for me, was infectious.
Yeah.
Right? Because for the first time, I'm seeing somebody that, like, he just really likes this stuff. Like, he just nerds out on it all the time, right?
Well, because I imagine there's more like curiosity involved with somebody like that, more compassion, more a lot of those kind of human factors that could be easy to sterilize through
That was
school.
precisely it. So he had retained that. I don't know how he did it, but he retained it through his training and came in just excited. Like, it was just interesting. So hearing him break down the case was interesting, and you know, even if you did something that was wrong, right, the way he had of walking you through, the point was not, you know, you're such an idiot for doing this, right? The point was, okay, you did a thing, it was wrong.
It was a learning environment.
Let's understand why it was wrong, right? So that the next time you don't do it that way, right? You know what to do to get it right. This was the attitude that he approached this with, and that was excellent.
Yeah.
That was excellent.
Sounds like a really refreshing, like, classroom setting
Very
versus what you've been having
very,
prior.
very much. Yeah, it really was.
Yeah.
And so the result of that was some inspiration to say, you know what,
Okay.
I like this doc, and I would like to be like him, right?
Yeah.
In this respect, I would like to be like him. I would like to know my area as well as he does. I'd like to be excited about it, right? I'd like to enjoy digging into the details of the science behind this.
Yeah.
And so that, that had a very prominent effect.
Yeah.
Had a very prominent effect.
On just you, or do you feel like that was like throughout the class?
I think it had that effect on many people, but it was variable. Some people responded really well to it. Other people had other priorities, just other motivations, whatever it was, right?
And your personality type, it sounds like, that's something that you'd already identified that you'd been lacking throughout this journey and wanting, especially after that family practice for the 2 weeks. And you kind of, that was the taste of freedom. But then now it's like another piece where you're finding some more of that bedside manner, that compassion, that why.
Yeah.
Maybe.
It's that, I would describe it, if you use athletic terms, right? It's like finding a good coach, right? Presumably you're playing the sport because you like the sport, right? But boy, is it helpful if you can find someone that has been there before you, and can help you learn faster, right? Can help you gain more skill, can help you avoid making the mistakes that they may have made, right? That's how I describe it. So that was a very inspiring experience. It was a very inspiring time. The flip side of that was that I began to dig into my cases more. That's how I describe it. I began to dig into my cases more. And I saw a couple things. One was I realized how sloppy, in general, the system of healthcare delivery really was.
What do you mean by that?
So I wouldn't just, like if a patient, so what I would do, for example, is that when I was on call, I would come on call with, at this point, most of these references were not digital. Right? So I had a bag of books, like textbooks, that I brought on every call.
I'm sure we're very sensitive.
Right? So, and very heavy.
Yes.
And, if I got called on an admission, I would sit down and read the chapter on whatever I thought the condition was before I went into the room.
Oh, just from the nurse's intake notes?
So like if the ER doctor called and said, I think I have such and such a case, right? I would read everything I had in those textbooks. I would read it all. If there was an online resource, I'd read that too. Right? Now this is thoroughly inefficient, right? Right. Because what you're supposed to do.
No wonder it takes so long for doctors to get in the room.
Right. So I would read all that stuff. I would go in and see the patient.
Yeah.
And then I would, of course, and then sometimes what you got from the ER wasn't accurate, right? So then I would go in and say okay, I came in here prepared to talk about whatever it was, and this is completely wrong, right? So now I gotta go learn about this totally different thing that I wasn't.
Would this be a different day, or let you re-see them, or this is
no. This would be so like
let's
just say you're on call at night, right? And they call you, the patient gets admitted from the hospital, they're brought up, right? So I would sit there and I would read, and then I would go in after I had read about their thing. I'd go in and talk to them for however long that took, and then I would come out and read some more, and then I would write their orders, right? This is all as an intern.
Yeah.
And I think I'd mentioned at some point ago, medicine ultimately, right, is about rapid sequence pattern recognition. You have to build that over time. Well, the problem is that you don't have that.
Right.
So how do you build it, right? Because you get fast because you know things, but you only know things by having learned them and then applied them and then applied them again and then read that algorithm again and then read it again and then applied it for the 14th time, right? And then it starts to imprint on you.
Right.
But you have to go through that process, right?
And it's different for each type of case.
And then each time, then this one comes in, it's a little variation. So it's like that other one, but then there's this part that's a little bit different. And then you got to figure out, well, how do I navigate that variation from the theme? And then how do I navigate that variation? And you do it over time. Eventually, you get to the point where you've seen most of the variations most of the time.
Right.
So you pretty much know what to do, right? You still get occasional ones that are off the normal, right?
Yeah.
But you build that. But to do that, you have to build that capacity, which is time consuming, right? And this is one of the interesting parts. So the culture in that aspect of the program was very work focused, meaning we want you to get through with stuff as fast as possible, right? And this was in this, and I think other programs as well, there was a word that was commonly used, which was efficiency.
Yeah.
Right. So efficiency, what it really meant was speed.
Right.
How fast did you see all your patients and crank out your notes?
Yeah.
Right.
Not actual efficiency.
Nobody
whether
cares.
It's well done.
Exactly. That's exactly it, right? So real efficiency is you do it fast and well.
Right. Like how fast can you do it well?
But medical training efficiency was how fast.
Yeah.
Period. Right.
Yeah.
So that was a fundamental problem, because I realized at this point, okay, to do this right, I can't do it fast.
Right.
I don't auto know enough of this stuff, right?
Yeah.
To just be able to walk into the room and break down your history just from talking to you and know exactly I know exactly what your condition is, right? These are all things I can do now, more than a decade out, but I couldn't do it that time, right? So I had to go through the time. So I had to have an interview with you. I had to ask you questions, and then I'd have to go read about it, and then I may have to come back and ask you more questions because I forgot to ask you some questions last time.
While that patient's still in the room.
Exactly, because you're still there, right? And before, I'm writing your orders, and then I realize, oh, you know what? To write this order, I need to know this other piece of information, which I forgot to ask, which I didn't even know to ask last time because I wasn't considering this condition. When I went in and talked to them, the history that they gave me was very different than what the ER doctor told me.
Right.
So now I really have to change gears completely, which means I need to go actually think about this other condition, and then I need to ask all the sub-questions that help me, fully lay this out properly.
Right.
So it was impossible in that context to be fast and good.
Yeah.
You could be slow and good, but you couldn't be fast and good.
Yeah.
But one of the first things I saw was the culture was fast. Fast, 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 fast. The second problem was that, again, to a large degree inspired by the doc that was teaching us, I began to really dig into the charts. So this was the beginning of the electronic medical record, for example.
Oh, okay.
Very, very beginning. They had their own record that they'd had built by a local company, right?
Oh, okay.
So the problem, the EMRs are terrible for so many reasons, but one of the things that they do is store information.
VMR is the
electronic medical record. Electronic medical record. So what we were doing, and this was true for a lot of my residency, was we were handwriting notes.
Right.
Right. You'd handwrite notes. The labs would be in the physical chart, right? You'd go flip through the page and note some stuff down, then you go write a note.
And past history would just be whatever's from that hospital.
Exactly. Whatever you had in the hospital stay, whatever the patient could remember, whatever you happen to know about them was what it was. But this was beginning to change at that time, right?
Okay.
So the electronic record, for example, didn't have all the notes necessarily, but it had the data.
Right.
So old studies, old imaging studies, old labs, sometimes old labs are in there, right? These other things were there.
Okay.
The culture was, you come in and talk to me about whatever, crank, right? Just get it through, whatever, okay, it's right in front of me, yeah. So I'll give you a good example. There was a case I had where this guy kept getting admitted for low potassium. And every single time, and I know this because I went and read his entire chart. Right. Every single time he would come in, they would say, you have low potassium. They would give him some potassium supplements and they would discharge him.
So what was going on?
That was the thing, right?
Yeah.
so what
why
was going
does he
on?
have low potassium?
That question was never being asked.
Huh.
No one was asking, why does this guy
including
keep
the
coming?
patient?
Well, this particular patient had some psychiatric issues, so he wasn't able to advocate for himself, right?
Yeah.
But he kept coming with a low potassium over and over, and it was just...
Which, how many times until somebody at the hospital goes, okay, why?
Well, the answer was a lot of times, and the answer before was nobody asked, right?
Wow.
Nobody asked. So I get this guy, right? And I take that, so I'm doing my thing, right? I'm like, okay, low potassium. Well, let me read about low potassium, right? This is my approach, right? Let me read about all the things that cause low potassium, right? So let me read that, and then let me see how it correlates to this person, right? When I go see him,
right?
And then as part of that, I would also do this intensive review of the electronic record. Right? And so I go back and see, well, this guy's been hospitalized like 8 times in the past year for low potassium. It was something like that, right?
Yeah.
And I don't see a single bit of workup. No one has done any workup on him for anything.
Wow.
He's just getting discharged and cycling back in and discharged and more potassium and discharged, right?
Wow.
So this was the issue, right? There was another one where the patient had an echocardiogram. So they'd had an ultrasound of their heart in the previous hospital. Well, no, it was like maybe a few months before. Okay. So I can't remember now why she was rehospitalized.
Yeah. Same hospital though?
Same hospital.
Okay.
Same hospital. So as I'm going through, I go through and I had a habit at that point of just, I would read anything I could find on them. Right? Yeah. I'd go back. And to this day, I still do that because you would be amazed what you find in the imaging that nobody has come to.
Right.
So I go through and they're like, oh yeah, there's this, possible mass, floating around, in the atria, one of the chambers of her heart. Yeah. So I read this and I'm like, oh, that's interesting.
Like a blood clot?
Well, there's a lot of possibilities for what that is, right? One of which is a tumor, right? And blood clot is another one. There's several different possibilities.
Different types of mass that it
could have been happening, right?
Okay.
But the point was that this was flagged on the echocardiogram.
Yeah.
So I read that and say, well, that's interesting. It was a few months ago. I wonder what that is. The patient didn't mention it to me, right? So I go talk to the patient and say, well, what was that about? And she's like, I don't even know what you're talking about. Nobody told me, right?
Really?
Yeah. So,
wow.
So then I try to go find old records, and I realize nobody mentioned it It wasn't mentioned in any available documentation. The patient has never heard of it.
So you just saw it in the actual scan?
It was mentioned in a report.
So it did get written somewhere.
It was put in a report, but it never got
mentioned to her.
To the patient, it never made it into her chart anywhere.
Yeah.
The diagnosis was nowhere. There was no referral to anybody to look into what this thing even could be. There was no follow-up testing or imaging done. There was nothing done. It was just a complete miss. It was just a complete miss, right? And so I was like, this is bad, right?
Yeah, right. To start off, it's bad.
Right, it's bad. And so in both cases, right, so we ended up doing more testing and trying to find the reason and got more people involved, right, and did things to try to right the situation. But my point in telling you that, and many other stories like it, was that I realized, okay, we have a problem here. One of the problems is we value cranking out work over the quality of the work. Even at the level of a resident, right, a trainee.
Right.
And that program is not the only one that does that.
Yeah.
It's to this day not the only one that does that, right? The problem with it was that they were treating the resident as sort of a means to crank patient visits, volume, whatever the case was, right?
Right.
With less concern about, is this person actually coming out of this as a good doctor?
Right.
Like fundamentally, are they coming out of it as a good doctor?
Well, because it's striking to me that, like, hearing you talk, and I could be wrong on this, but I feel like I have the assumption that prior to talking with you, I don't know much about the medical journey of the medical school process. But in my mind, I'm thinking you get done with medical school and starting a residency, like you must have already had so many hours following these different doctors around that you have this, what did you call it, the sequence of
the rapid sequence
pattern recognition. Yeah, where it's like, oh, this person must already have that because they're off doing it by themselves now. And it's like, and that's just sounds like it's totally not the case. This is the actual learning ground still in a way that maybe is not quite even understood on a lay person's level.
You can hear again, people grasp the analogy better with athletics, right?
Yeah.
So it'd be like saying, I had a coach in junior high that taught me how to shoot a basketball. Right. I know the proper motion to, I'm not going to do it. Right. Okay.
What is the
because I don't know the proper motion. Right?
No.
I know the proper motion to shoot a basketball, right?
Yeah.
But it'd be like saying, well, okay, junior higher, right? You now know how to shoot a ball properly.
Right.
So let's just put you in the NBA now.
Right.
Right. And get out there and shoot, right?
Right.
You're a 6'5" junior higher, right? Get out there and shoot. Well, why can't you shoot? Right?
Yeah, I mean.
Well, the reason is because there is, here again, we'll take basketball, there's so much more to the game you need to understand. And there's a certain maturity process you need to go through, right? You're just not generally going to be able to do that, right? Even if you know the basics. And I would say medical school in many cases is similar. You get a basic foundation, right? For example, you don't know every answer to everything, but you have a better idea of where to look to find answers.
Right, yeah.
Or who you could talk to maybe get more insight, right?
Yeah.
But the process of becoming a mature clinician is a lengthy deal, and it's not done by the end of medical school by any stretch of the imagination for anybody that I am aware of. Let's put it that way. Again, maybe you have a exceptional prodigy out there that was brilliant by the end of medical school, but in general that is not true. Right. You come out and you're trying to now apply. You learned a lot of disparate facts and things like that, and equations and various things. You're now trying to apply them, but they're in real time. And again, here's the contrast. Going through medical school, you are generally judged on your success with tests.
Right.
But a test is, let me give you a question prompt that's so long, and then here's 5 choices, right? Pick one of the 5 choices that's correct.
They're multiple choice.
There are multiple choice tests, right?
School?
Yeah. It's the whole thing.
Because there's too many.
The whole thing is multiple choice. Yeah.
Ah,
I mean, occasionally you'll get some free response type testing that does go on in certain specialties, but in general, it's all the way into medical school and through. It's multiple choice testing, right?
Yeah.
So the difference is that the patient doesn't come in and and you read a multiple choice question, right? You know that if they're mentioning or not mentioning information, right, that's relevant to what choices you have. The patient just comes in and tells you a 35-minute long story, right? And in the process of that, you have to parse out of that what's important, what is not of any value from a medical perspective, right? What is not even true, right? The patient may tell you information, and they may believe it, but it's also wrong, right?
Or just not even having maybe some of the information, like you're saying, the man that had low potassium, like if they were not able to advocate for themselves, like that's sure a lot of the cases too.
Also true. Unable to give you any information. So you have that, and then out of that cloud, you have to try to get to some kind of certainty and some kind of an answer, right? So it's just very, very different than that is a skill, and it takes time to learn that skill.
Right.
Here again, the problem is that if we take people and we grind them through a work process and we say the only thing we care about is how fast you get through this,
right,
they don't have the time to do the learning necessary to build out their own skill set. And what that results in down the line is a less skilled, less confident, less good physician.
Right.
Right? Because they don't have the time.
Because they've learned how
necessary.
to do
They've
it
learned
fast,
how to cut corners,
but not
right, and
well.
skip things, right, but not necessarily well. So they haven't learned how to do a deep dive into the information. They haven't learned how to think about and question the assumptions. So, like one important skill clinically is when you're working in a hospital, the ER is going to call and give you a certain story, right? The ER story will be wrong a significant percentage of the time.
Right.
It will, right? It'll be wrong. The ER's diagnosis will be wrong a certain percentage of the time. If you don't think about it properly, you will accept their diagnosis as correct and just proceed down a treatment pathway, right? So in other words, they'll call up and say, what, the diagnosis is pancreatitis.
Right.
Right. Well, if
this is like in a case where like you have a patient that's gone to the ER over the weekend or something
exactly.
that you're seeing later
well,
on.
let's say you're
like
working
after.
let's say you're working in a hospital as a hospitalist, just for example, right? So the emergency room may call you and say, so-and-so's down here, they've got XYZ, right? They've got pancreatitis, right? You need to put them in the hospital. Okay, so one approach is, okay, it's pancreatitis, right? I know what to do about that. I know what the treatment is for pancreatitis. I'm going to get you in. I'm going to order this. Check. You're treated. I move on.
Right.
Very efficient. Efficient. Right? The problem is, what if they don't have pancreatitis?
Right.
And the problem with that is, if you didn't actually analyze any of the data, you may be completely wrong. The ER was wrong, and you have perpetuated the incorrectness because you didn't question any of it.
Yeah.
Because you don't have the habit of primary processing and correcting the thing, right?
Right.
So you only find out that it's wrong days later when things are suddenly going sideways, or the patient's not getting better, or maybe you never get it right. Actually, you misdiagnose the patient, you incorrectly treat them, you give them incorrect information, you discharge them home, and 2 weeks later they bounce back to another facility in a different place where they finally get it right. Or maybe they don't and they mess it up also, and then 3 or 4 or 5 admissions later, someone finally catches it.
Yeah.
As it slipped through every single time because they have a history, right?
Yeah.
These are real things that happen in hospitals.
Right.
I'm not just spitballing or giving a hypothetical. These are real things.
No, yeah.
But a lot of this starts with, I want you to crank out as many people as you possibly can in the time allotted, right?
Right. That being the main priority.
The highest value.
Yeah.
Yes, right.
Yeah.
So this was in my case one of the biggest problems, right? And then another problem that existed specific to that program was that many of the senior residents, they were more focused on going out to moonlight and make extra money than they were on necessarily their in-rotation clinical responsibilities at that time. Okay. So a very common practice, here again, people may shudder when they hear this, but this is what was going on.
Yeah.
So you'd be the intern, let's say you have 9 patients, right? As an intern, that's a fair number of patients in an inpatient setting, right? Because again, you're learning, you're slow, you're not as fast as you will be later.
This is over like a 12-hour shift?
Yeah, you've got a 12-hour shift, you've got these 9 patients that you're carrying up, then you may have admissions, so it may go a little higher than whatever it is, right? So what the senior residents would do, like let's say it's a weekend, they would show up, they would round on, let's just say 12 patients or 15 patients in 2 hours, which is, if anybody has ever knows anything about running, that's a blindingly fast duration, right? That's a really fast way to get through rounds. And these would be ICU patients, like these would be people that had legit stuff going on. Yeah. They'd go through it in 2 hours, they would leave, sign out their pager to the intern, right? And leave and disappear, like be unreachable for the entire, be unreachable. Right? They would be unreachable because they would say, I've done my duty here, which was to see these people. I did it. I got through it as fast as possible, and I'm going to go out now and go do this other job that enables me to make money, right? And then I'm gonna sign up. So you as the intern would start getting these calls on people you don't know anything about, right?
So about these same ones that they already saw?
Because they saw them and then signed out on them, but then other things come up through the day. There's always questions, a test comes back, the treatment didn't work.
Family members needing
whatever it is, right? Yeah. And so you would get called and you wouldn't know anything about this patient, right? And you're then trying to figure out who they even are, right? Right. You wouldn't get any sign out in many cases. Like they wouldn't even tell you about the patient. They would just leave. This again was the culture of the place. So you
wouldn't be with them while they did those rounds.
You wouldn't. They would go off and they'd see their people. You'd see your people.
I see.
Right. And then you might meet to round with the attending or something at some point. But in some cases they would just bounce. They do phone sign out to the attending, so you weren't there for that, right? And then they're gone. And I mean gone. You can't reach them. So, so you'd get these questions, and in some cases you couldn't, so here, I'll give you an example of it. So I get this call at one point, it was a weekend. I get this call saying, so-and-so has just come back from surgery, and we want to know when we should restart their blood thinning medication. And I'm like, I'm sorry, I don't know who that is. They're like, oh, it's Dr. So-and-so's. I'm like, oh, okay. So it's one of these situations where the doc saw them and pieced out. So I go read the chart, and there's no mention of it at all.
Of the blood thinning medication?
There's not even a mention of it, right?
Oh.
I'm like, I don't know what med they were on. I don't know why they were on it, which is critical in this type of situation. Right? Why were they on it in the first place? Right. So I eventually figure out what they're on, but I still can't figure out why they're on it.
Yeah.
Right. And this was a situation where the patient had been handed between a couple of different residents, right? All of whom were just zipping through, being very efficient, right? But nobody was actually writing anything that was useful, right? In terms of information for an outsider to read to understand what's happening to the patient.
Right.
The patient doesn't know. Nurse doesn't know, right? So what
they only know that there is medication that they're supposed to have, but like not.
So I couldn't reach the person that had rounded that day at all. So then I went back to the chart and found the people that had seen the person before they had handed off to this person. Okay. I called some of them, and in the end, nobody knew. No one knew. Yeah, one person knew that they were on a blood thinner at least.
So that got thrown in the mix somewhere, but then with no context.
But nobody actually knew why they were on it or what they're supposed to do. So here again, now I'm sitting here as the intern.
Yeah.
I'm the person that knows the least in this entire group of people, right?
Of all these
and
people
I'm like,
you've called,
I now need to decide whether I start your blood thinner or not. I don't, so my response to that is, well, let me go do some reading.
Right. Because like at this point, do you even know like how soon after surgery you can
this is
start?
the thing, right? Yeah, no, I didn't know that. That was not an issue that had come up before, right?
Like you're still trying to answer the questions of like, okay, why do they need the blood thinner?
Yes,
like, do they need the blood thinner? And then you have to figure out all the other pieces of.
And then when do you restart it, which depends on what surgery they had and what was the reason for being on it, and
what other medications they're
on.
All
kinds of other things, right?
All those factors.
This was the type of thing that went on all the time, like all the time. Wow. And so in that context, while all that was going on, so here again we go back to the point of this was to describe how I got disenchanted with medicine.
Yeah.
So I'm here saying we are not doing our best work here.
Because you got enchanted by medicine.
Yes,
honestly,
exactly.
It's really what happened, and then
correct.
You got disenchanted with the structure that we put medicine in.
That's precisely it.
Yeah.
Because on the one hand, I'm like, I really like this.
Yeah.
Like I really like it. I enjoy learning it. I love reading about it. I like thinking about it. I'm reading stuff. Nobody's requiring me to read anything. I just read it because it's awesome and I want to learn, right?
Yeah, you're following curiosity, which is always that's a good point. That's a good indicator of that you're doing something that's worthwhile for you. I mean, honestly.
In that sense, right? In the other sense, then you go see how it's being executed on a day-by-day basis.
Right.
And it's like this is just sloppy. Like, and I want to differentiate here. This is not just like somebody made a mistake.
Right.
Do you know what I mean?
Yeah.
Anybody in medicine can make a mistake.
Right.
You can like we mentioned before, you can make the right call for the wrong reasons. You can make the wrong call for the right reasons.
Right.
These things can happen, and that's not the issue. The issue is when we are sloppy.
Right.
Meaning the information was there. We just didn't seem to find the time to just go read it. Right.
Well, because it's like, I mean, it really sounds like it boils down to investigation. Like, and it's like if you're a cop and you walk up to what appears to be a suicide and, it may be or it may not be, but you don't do the due diligence of going through. You just go, yeah, it's a suicide. It's like something maybe seems obvious. Maybe it seems like a science fiction, but if you're not given the time or the wherewithal to actually investigate like you need to, then, I mean, that's a totally different scenario.
So to that point, right, here's again what I mean. So I had a patient, this is again as an intern. I come in the morning and it says, patient came to the hospital because she reported a differential in the size of her breasts. She thought one breast was more swollen than the other.
Yeah.
I asked the night resident, what do you think? She's crazy. She's just crazy. I said, okay, well, I mean, how do her breasts look? Like, is there a difference? I don't know. I didn't check. She's crazy, right?
Oh, wow.
Really, truly. Like that was the actual response. I didn't even check. She's just nuts, right?
So which like that, honestly, that's one of people, I think a lot of people's number one fear and frustration with healthcare is not being believed.
The issue was when you went and talked to this lady, right? She did have some mental health issues. Yeah. She did. But she was able to speak to you. She could describe her symptoms perfectly fine. Right. Yes, she tended to go off on tangents and had some exotic beliefs. But this is a person sitting in front of you. They're telling you they have a problem. They can tell you how they have the problem. They can describe it to you. Fine.
Right.
And all you have to do is take them at their word and check.
Right.
So you know what I did that morning? I took her at her word and I checked. And you know what? She was right.
Yeah.
And you know what? Then we did some investigation and we found, oh yeah, she had a real problem, right?
Yeah.
She had a real problem. There was a diagnosis that needed to be made.
The owner of this body
right.
actually knew what was going on with this body. What?
I mean, and as mind-blowing as that is, right? That approach was distressingly common. It was distressingly common. But at the heart of it, so here again, now you could take that and say, well, that was just a bad resident. No, this happened too many times with too many different people. Right. You begin to realize at some point this is a system issue.
Yeah.
Right. And the system issue is the American healthcare system cranks volume because volume makes money.
Yeah.
And the problem with volume is when I'm cranking as much volume as I possibly can, I can't be as thorough and detailed as I need to be to do good work.
Right.
Right. And the other problem is, on the one hand, you've asked me to crank volume. On the other hand, you've given me very suboptimal tools to work with.
Right.
What I mean is, you haven't, for example, given me a medical record system that has all their information in it.
Right. Which we're working on now, and and
vaguely,
yeah,
yes.
I know. I
it's
just
for
the other day had my first time ever actually arriving at a doctor that I regularly go to.
Yeah.
And they handed me an iPad and it had all my stuff already in there, and I was like, oh yeah, it's all the same. Like that was literally last week, and that was the first time in my 33 years that that's happened. So like we're working on that part. It sounds like, but.
Barely.
And so you mentioned that you did change your residencies. I want to talk about that next time. We're kind of running out of time this week, but next week I'd like to talk about some of that change of residencies and kind of what the change looks like from you. It sounded like you really found your passion in this residency year here in Wichita via Christie. And what was the doctor's name that was the one that would do the noon conferences?
Yeah. His name was Johnny Musa.
And so, I mean, it sounds like Johnny Musa really brought that out for you, of that curiosity, that joy, that like investigative, side of it that I'm sure is part of what makes you so tenacious with what you do, because I see that in everything that you've shared so far. It's like you have thought about it in those investigative ways where you're not just asking questions about the healthcare system, you're asking, why is it that way? The same way that you would ask a patient, like, not just what we need to do about your low potassium now, but why is it that way? So thanks for being here. Thanks for your curiosity. And we'll pick up next time on the last bit of your residency and how you kind of started off into the real world as a doctor.
Sounds good.
Awesome. Thanks.